Okay, let's start the second part talk. The talk is early palliative care for oncology patients in Taiwan. I will be focused in 5 topics. What's early palliative care? Why they need early palliative care? What's the efficacy? Integration of palliative care into standard oncology. Advance in early palliative care in Taiwan. So we move to first early palliative care. As we know, hospice, palliative care, and supportive care are patient-centered focus. About the modern hospice, began in the UK in the 1960s. Cicely Saunders, a British nurse and a social worker, initiated the concept of the hospice. The concept of hospice are total pain, including physical, spiritual, and psychological discomfort. And they need the family member and the friend who provide care for the dying. And the palliative care, the common agreement was the first mentioned by Canadian surgeon Buffalo Monks in 1974. He mentioned about the multi-dimensional assessment and the management of severe physical and emotional distress, multidisciplinary care for multiple disciplines, and in addition to physician and the nurse. And he emphasized on the caring not only the patient, but also their family. And the supportive care is a concept since 1980. Somehow that non-palliative care is a similar focus on the individual patient with cancer, the host, not the tumor. So he supported management of the treatment-related effect. In 2002, WHO declared a definition of palliative care. So palliative care is an approach that improves the quality of life of patients and their family facing the problem associated with life-threatening illness through the prevention and the relief of the suffering by means of early identification and impassable assessment and the treatment of pain and the other problems, physical, psychological, and the spiritual. So they mention about the concept of early. There were 5 main ideas from the WHO declaration. First one, for quality of life focused approach, whole human approach. Care encompasses both the patient and those involved with the patient, particularly caregivers. Respect patient autonomy and the choice. Support people through frank and through full discussion on difficult subjects. So it's a concept to not just mention about the treatment of the cancer. So it's also need the caregiver to be involved in the palliative care. Today, I will talk about 2 palliative care models. Those you can find from the literature. One is a time-based model. And then from the figure, you can find the patient have the newly diagnosed advanced disease. We can start palliative care for them. It's a model, say it's a time-based model. This another based model. It's a provider-based model because the patient have the newly diagnosis could be have the diagnosis in different hospital, maybe in the private clinical, maybe in the regional hospital or in the medical center. And the different health institution have the different power to supply the palliative care. So if the patient just receive the palliative care by their physician, it's a primary palliative care. For the patient in the hospital or the institution, they have the palliative care and the primary care physician command to take care of them. It's a secondary palliative care. Tertiary palliative care is the patient need the complete palliative care team service and the main oncology treatment team just for the support. So this kind of institution or hospital where we have the palliative care ward. So the different hospital can provide the different level of palliative care for the early diagnosis of advanced disease. The advocacy for early palliative care come from the Dr. Timel report the early palliative care for patients with metastatic non-small cell lung cancer in 2010 in the New England Journal of Medicine. So after that, we more common hear about this concept about early palliative care. So second part, I will explain why they need early. From the figure, we can find if the patient have incurable cancer, they can have the problem from the cancer diagnosis, staging, and treatment. They also have the personal need from acute or chronic psychological problem. They also have the comorbidity. So in the clinical practice, the patient maybe have the acute issue, chronic issue, psychological issue, and the spiritual issue. So we cannot care this patient, just focus on his disease. From this slide, we can find all these kind of problem could be suffering the end of life. So if the patient have the social concern about the caregiver support, family interaction, they maybe have psychological concern about the coping, anxiety, and the depression. So this not really can help by the physician alone, because they need multiple dimensional management. So if we can provide a palliative care for them, they can have optimized quality of life. They can have multi-dimensional measurement and the management of their caregiver. They also can have the multi-professional approach. So the care quality will be more improved and more valuable. So third part, I will mention about, are there any evidence about the efficacy of early palliative care for the advanced cancer patient? First one, the randomized trial published by Tamer. You can see they recruit 150 patients with newly diagnosed metastatic non-small cell lung cancer. They randomized the two groups to one early palliative care group and one standard oncology care group. Their results show the impact of early palliative care on patient-reported measures. One is quality of life better, and the less symptom of this early palliative care group. And the quality of life and patient survival also can find the better of the early palliative care patient. Let's move to second randomized trial, ENABLE-2. The trial randomized 322 patients with newly diagnosed advanced cancer. They randomized to palliative care intervention plus standard oncology care versus standard oncology care. So the trial results show the benefit of early palliative care in quality of life, symptom control, and the mood. The same result like Tamer study. The third trial recruited more than 200 patients. This trial analyzes about the chemotherapy utilization. For the early palliative care patient, because of the multidisciplinary team discussion about the treatment choice, so they just receive first-line chemotherapy alone is less, and they more likely to make decision about the third and the fourth line of chemotherapy. And how about the patient use IV form chemotherapy within 60, 30, and 14 days before death? You can find the early palliative care patient more easier to make decision stop of chemotherapy. So they use most line of chemotherapy, but they have chance to stop chemotherapy more early before time before their death. Another study evaluated the cost at the end of the life by category. You can find the data in the table. The early palliative care patient have less inpatient visits and more outpatient visits, and more patients accept hospice service. About the Cochrane Library review about the early palliative care in 2017, the conclusion is early palliative care might have more beneficial effect on quality of life and intensity of the symptom among patients with advanced cancer than among those given usual or standard cancer care alone. The effects are of clinical relevance for patients at an advanced disease stage with limited prognosis, when further decline in quality of life is the truth. So from those randomized trial and the Cochrane Library review, I think we can make some conclusion about the benefit of early palliative care. It can improve quality of life, quality of end of life care, decrease rate of depression, illness understanding, and the patient satisfaction. After the evidence presentation, I think we need to discuss about how the integration of the palliative care into standard oncology care. From ASCO guideline, the guideline states that inpatient and outpatient with advanced disease should receive dedicated palliative care service early in the disease course, concurrent with active treatment. And so they give this strong recommendation to integration of the palliative care into standard oncology care. So it's need to early and concurrent with active treatment. This figure show you the different initial timing for the traditional versus early palliative care. For the early palliative care, if we want to manage symptoms and improve quality of life, it need to initiate before 8 weeks as cancer is diagnosed. This is the same figure I show you in the beginning. So you can use the different model of palliative care for your patient according your institution and according the the professional resources for the palliative care. So the patient maybe receive the primary palliative care, maybe have the secondary palliative care, or the tertiary palliative care. If you want to successful integration of palliative care into your oncology practice, those indicators, all of them you need to management. So you need to management about the education, clinical structure, research, administration, clinical process. Just I mentioned about the administration. They say about the reimbursement. Even in Taiwan, we did not have the reimbursement for the early palliative care. So I will mention later. This is a very interesting article published in the recent. They discuss about the education for the advanced practice nurse. So they made a conclusion. Advanced practice nurse should be educated on the principle of palliative care, as they are perfectly situated to advance the integration of early palliative care in the oncology setting. So I think even in U.S., this is a study from the Midwest Cancer Center. So I think in Asia, we also need to provide this kind of education for the nurse, for the physician, for the multidisciplinary team member. So let's move to talk about advance in the early palliative care in Taiwan. From the Health Promotion Administration, the fourth phase of the National Cancer Prevention Program, they mention 6 strategies. In the 5.2, they discuss about the importance of the hospice and the palliative care. So since 2018, our HPA promote the cancer prevention and the treatment institution should establish early care center and the procedure to provide early palliative care for patients with advanced cancer. So this is a requirement from and the plan or strategy from the authority. How about the accreditation of cancer care program in Taiwan? Right now, we have about 60 hospitals pass the accreditation of the cancer care program. In the new accreditation standard 3.3 since 2019, there have the requirement cancer prevention and the treatment institutions should establish palliative care standard and the procedure for patients with advanced cancer. So from the accreditation also have the standard requirement for those kind of patients in Taiwan. So I will start to show you a case received early palliative care in our institution. From the ASCO guideline primary criteria, this one before adulthood. We have a 17-year-old male. He suffered from intractable cough with sputum for 4 months. He was referred to our hospital because the chest X-ray find a lung tumor and a pleural effusion. CT scan showed the right lung tumor with pleural effusion. So during the ER visit, he have high fever, slight hypoxemia. So the chest surgeon performed the blood decodification and the tumor biopsy. The pathology diagnosis yolk sac tumor. So this is a chest X-ray, and the CT scan. You can find the big mass in the right lung. So before he start to receive chemotherapy, we have another diagnosis as he had small testes and were noted by urologist. So the chromosome study confirmed he is Klinefelter syndrome. Before chemotherapy, we also disclosed his mother had the psychological distress, and the result he has sad brain and some suicide idea. Talk about this patient. He dropped out from school because bullying for years, and also had a bad father-son relationship. So as find those problems, so we arranged the integration of our early palliative care in a team for care of him and his mother and the grandmother. So after that, the patient even received multiple chemotherapy, multiple operation, and including autologous PBS-CT. This day he got the engraft autologous stem cell transplantation. Even he have the disease recurrent, but he back to school in this summer. So this is our successful early palliative care case demonstration. So my conclusion, patients with incurable cancer present palliative care need throughout the continuing of their disease. There is increasingly robust level 1 evidence of the benefit of palliative care for patient and the caregiver. The published randomized trial on the subject point to health gains resulting from integration, but what, when, and how to integrate are yet to be established. Palliative care should be part of national cancer politicals and plans. My talk will stop in here, and your question and the comment were welcome. Thanks for your listening.